available on, and even Professor Ocano and Professor Trimaci have also connected, so they can accept questions too. Although we didn't hear the lecture.
So are there questions from the audience? We have something like 15 to 20 minutes till the end of the session. Yeah, please.
I don't know, yes. It was a very nice presentation. I'm very glad to be here. I'm from Mexico, and I have a clinic of nasal polyposis in Mexico. And I operated one person. It's just this patient that helped me a lot to understand what was happening. He had already 10 surgeries, 10 endoscopic surgeries before getting to my hands. And when I saw him, he had a grade 4 polyposis and all asthma, but he has no aspirin intolerance. So when I performed the surgery, it bled, and it was a hard revision surgery, a lot of fibrosis, and at the end it resulted to be a Church-Strauss. No? So it's very interesting to have a high index of suspicion, but what is very important is to see that this patient had already been treated for more than 15 years in different centers. And it's because he got to a very specialized center that he finally got to the diagnosis. And what we saw in those polyps was a huge amount of fibroblasts that we thought could be related to all the previous surgical events. But they told us that also it could be because of all the vasculitis that had been over the years. So I don't know if all the speakers here could comment about that. All the intense fibroblastic activity that was present in the polyps, and not only in the polyps of the previous operated sections, but also in the non-operated sections when we got a lot of polyps full of activity.
I think you're it's a very interesting case. It's a very typical case, and it's excellent that the patient was diagnosed. I think the problem is that we don't absolutely know, because we don't know the natural history of what happens to polyps in EGPA, because once it's diagnosed, then they get treatment. But what you're describing is likely a end point of the disease, because we certainly see, and my colleague will correct me, I'm sure, you see it in the lungs when patients get lung involvement or kidney involvement. I mean, there is often residual damage as a result, even if there is healing of the granuloma and the vasculitic process settles, you are left with residual damage. I liked your photograph of the burning house and the burnt house. I mean, that you're in the burnt house situation when you're dealing with that. And I suppose, the message is the earlier you diagnose, the earlier you get the patient on drugs such as MePO, then the better the chances to avoid that damage. And I think that's the great difficulty sometimes when you're dealing with these limited diseases, as to how aggressive you are with your medical treatment to sort of stop that natural history progression.
Okay, I do agree. I don't have anything much to add on this, but my only comment, fibroblasts are not a typical histopathologic feature of these diseases. So I can assume that it was a result of abnormal healing procedure due to the previous 10 surgeries you mentioned. I think this was the reason for having this very specific histopathological finding. Otherwise, I think that everything has been mentioned.
I would also suggest that those patients with massive polyps and asthma, if you do systemic eosinophilia, usually in Church-Strauss is much higher than, and if it's over some limit of 15, let's say, % peripherally, very easily you can check the antibodies and you will be there, because vasculitis is not always easy to find on samples, no?
Absolutely.
Yeah.
Can I just ask about the question of the transition from limited to systemic involvement? Do you think every case, eventually goes on? What do you think happens with patients?
No, I don't think that every case proceeds or progresses from a localized disease to to a more systemic vasculitis. I think that it depends, although, you know, we don't have any data on this. It depends mainly on the early diagnosis and probably to the better management of the disease, because we are coming last month, a patient with symptoms for more than 1 year with polyps, relapsing polyps, fever, a short course of steroids. She did well, and after a year, she presented with asthma, polyps, and renal involvement, and nobody had checked ANCA antibodies. So I think that if we have an early diagnosis and we manage patient properly, it's less likely disease, more systemic vasculitis to be developed. Also, even if you diagnose a patient with localized ENT involvement, then it's a good thing to have an annual review by a rheumatologist, because, you know, you are seeing different things when you have a patient in front of you in the clinic, and we are looking for different things. So this collaboration may be very beneficial for the patient at the end of the day, in order to have an overlook, a better look of the whole condition, rather than localized systems.
No, I think that's a really good point, actually. If you have that collaboration, you might not realize that their renal function is deteriorating or they're getting lesions in the lung. So that regular review is really useful. I mean, I often saw patients over many years who seemed to sort of burn out eventually, or were just kept on a very small dose of, say, 5 milligrams of prednisone as sort of replacement of their own cortisol. So it sounds as though, you know, there are a group of patients with limited disease who might also go into remission. We don't know, because we can't ethically follow up patients once we've decided they've got the condition without giving them any treatment. But it's quite interesting to speculate how many would actually simply settle down. It's intriguing.
Yes, this is something which is quite common in rheumatology, because we have burnt out rheumatoid arthritis, for example. Patients completely disabled with the hands, but they have no pain. Yeah. They are not taking any treatment, because this is exactly the term burnt out. So something similar, it's what you are describing now regarding renal and nasal involvement. And to be honest, because these patients with destructive nasal disease mainly are looking for an ENT surgeon and things, we are not seeing them first. We are not the first physicians seeing them. Usually, they are referred from you to have an evaluation and to see them.
Yeah, I think the point is managing expectation is always the name of the game, isn't it? So you really try and get the patients to understand why you're asking them to wait a little while before they have anything done, because it's in their best interest not to rush to have something done if their disease is active.
Yes.
Because in the long term, that won't necessarily result in the best result.
If I may, my name is Eliza, and I would like to ask you about, well, first to share one observation about pediatric patients with granulomatosis with polyangiitis. I've seen, well, I had only 10 of those pediatric patients, and they were diagnosed after 3 to 12 months of observation. So it was quite a long time after having primary symptoms. And I must say that only one in a group of 10 children did not develop generalized disease. So localized it was in the beginning. Usually they had nasal symptoms, but only one remained only with laryngeal symptoms. She had blood stenosis. But I have a question: what to do if patients, like for example with sarcoidosis or GPA, have this localized disease, which is very severe, and general physicians, they don't want to treat them, they don't want to administer any cyclophosphamide or rituximab because it's too early. Because, for example, in sarcoidosis patients, if they have only one localization of the disease...
Excuse me.
Yes?
We have Dr. O'Connell, who has submitted his presentation in IgG4, and we should respect the idea that he speaks to us from Japan. But I just ask you to be sure, because we have 10 minutes left for the session comments. So please, you can start your presentation.
Should we make a comment in the
For the
or
question.
to the question first?
Yeah, you can shortly answer it. because-
Okay, I'm an adult rheumatologist, so I'm not seeing children because in our department there is a very well organized rheumatology pediatric department. But generally speaking, all these severe systemic diseases, including lupus and vasculitis, when they are presenting in younger age, in children, tend to be more aggressive, particularly if they have this type of systemic and severe, even localized disease. So what I can say is that the cases that you mentioned are, you can see them in this context of a severe disease developed in a child. When you have a child, the follow-up it's different, as far as I know, compared to an adult patient.
And with your second part of the question, I think if patients are reluctant to have treatment, you've got two options. You have to let them know what will happen potentially if they go on to get systemic disease, so that they know they can contact you or your colleagues as soon as possible when those systemic symptoms start. I think that's the only way you can manage
Okay,
the
thank you.
Thank you.
I would like to start. We will probably get